Thanks for having me here. This is not something I usually do, so bear with me. I think it's the first PowerPoint I've tried to make, so I don't have a lot of fancy effects. Many of you probably make all sorts of cool ones. I'm here because I think Carrie Meyer from Dane County had gotten me in an email loop about being involved in education, and Spring Green needed some education, and their medical director said, well, maybe Dr. Morgan will do it with soft. And so here we are, and it's great to do this collaboratively. It makes sense, right? And I'm not sure how long your meetings usually go, so if I start going too long, please tell me. My goal here was to go through the objectives that Carrie Meyer sent from Dane County, but then to also just add some stuff that maybe is a little more interesting as far as a little more case-based approach. And I also thought it would be helpful. There are people of all sorts of backgrounds here with all sorts of different experiences and skills, and I thought it might be helpful to add a little bit more than the basics of what is in the list of objectives, just as far as, when you bring somebody and you drop them off at our ER, what happens next, or what are we looking at, or what do we do with the information that you give us, and what's our next thought process? I think that's a good thing in general for all of us to think ahead to, well, what happens next, and how can we kind of help that transition along, right? Whatever level we're at in this healthcare business. So, endocrine emergencies, but really what it's all about is diabetes. That's what they wanted to talk about. So, this is the list of objectives from the handout that I got from Carrie Meyer and Dane County, and you can read through those. Basically, a little bit about glucose, insulin, hyper and hypoglycemia. They wanted us to talk about metabolic syndrome. I don't think that's something you really assess, but it's in their objectives. We'll touch on that. And then we'll go through some of the management and talk briefly about insulin pumps. If anywhere along the line you have a question, please stop, raise your hand. I'd like this to be interactive. If you need to go out and get some food, get some food, okay? So my objectives are to try to do some case-based learning, useful information, learn what you need to know, plus the next step, or at least the next thought in patient care. Have this interactive and hopefully a little bit fun. Your objectives, hopefully it's not too boring or too long, right? That it's useful and that it satisfies your training. So here's case one. So EMS, you're called out for a diabetic issue, no other reason. So on your way, you start to think about diabetic emergencies, and you think about hypo or hyperglycemia, right? It's totally different. You've got your training with initial assessments, and you guys have talked about all this sorts of stuff. I think this is the terminology, right? Pretty standard stuff. You think about your differential diagnosis, right? Maybe there's something else going on. You've got some management tools. You've got glucose and dextrose. You can give glucagon if you need to. You can give fluid. And you transport the patient. So you think, hey, maybe we'll just pull out our protocol while we're driving over there and blow it up. And that's the first part of it, right? And you guys know this stuff, right? You got your pediatric one. So we're not going to sit here and go through all this. You guys do that, right? We're going to just talk more about stuff, okay? So you get there, and there's a 73-year-old lying in bed, and his wife says he's got diabetes. She's afraid his glucose is low. She doesn't know how to use the meter. She's just worried, and she tried to wake him up. She called 911. And he's confused. He's a little diaphoretic. He's got a rapid heart rate. You just feel his pulse, and you check his glucose. It's 33. Okay. I think this is a pretty routine call for you all, right? So you decide, I don't think this guy can take oral glucose. I'm not convinced that's safe. So you're going to give him some glucagon while your partner gets an IV ready. Okay. So. First question, and let me back up. I put some questions in here as a means to just start thinking about stuff. Some of these are material that is beyond what is expected with this talk, but it's interesting stuff. So that's the purpose. It's not to make you feel like you don't know what's going on. Okay. So this one, though, pretty reasonable. Which hypoglycemic patients are least likely to respond to glucagon? So we'll come around and we'll look at these questions at the end. Okay, but just food for thought. So patients with CHF, liver disease, obesity, coronary disease. If you're already looking at a patient, you might be thinking, boy, I don't know if glucagon's going to work, right? And those are some of the clues. So you give your glucagon, and your partner's got an IV in, you're going to give some dextrose, patient gets better, looks good, right? So I know your protocol allows for maybe they don't get transported if they want to say I'm good, right? There's the opportunity. The patient's wife is able to tell you the medicines he takes. So from our standpoint, if you bring in a patient, we're going to want to know, well, why did he get so low? Is he going to stay low? Is he going to be low again in an hour? Or is he fine, right? So which medication of these is the most likely to cause prolonged or recurrent hypoglycemia? And you may not know this, and that's okay, but we'll just talk about it. Because you guys get all of these medication lists, right? And it's hard to know, are these accurate? What do they really take? But sometimes there can be a clue as to what's going to happen next based on how they treat their diabetes. So we'll talk about that a little bit. Here's another case. So you called out 19-year-old. This is sort of a version of a patient we saw a few weeks ago, real sick. 19-year-old woman with diabetes, vomiting, lethargic. And you get there, she's lying on the couch, she looks ill. She's not right. She's clearly ill. And you rapidly assess, and she's not responsive. She's breathing abnormally. Her airway's fine, but her breathing is abnormal. She's a little tachycardic. Her skin is a little cool. Doesn't look like there's trauma. And the roommate tells you, yeah, she got diagnosed with diabetes a couple years ago, and she was vomiting. I heard her vomiting all night, and this morning she was lying on the couch and she's unresponsive. So this is probably not as common as the first case, but this is another diabetic emergency. So here's a question, just food for thought. We'll talk a little more about this, but I told you the patient's breathing was abnormal. I didn't tell you exactly what it was, but if you think about that, diabetic emergency, 19-year-old, diagnosed at age 17, and she's not right. She's unresponsive and she's breathing abnormally. Well, why is that? Is it because she's got catecholamines, like all this adrenaline, and that's making her breathe fast and rapidly? Or is it agonal breathing because her pressure in her brain and skull is too high? Or is it periodic breathing where people breathe a bunch and then they kind of don't breathe, and then they breathe a bunch and then they don't breathe because the way they sense oxygen and carbon dioxide, is that normal? Is that what's going on? Or is she doing this rapid deep breathing with an increased volume of air with each breath and a fast respiratory rate producing this really high degree of ventilation? So we'll talk about that, okay? Just food for thought, all right? So you complete your initial survey, you're efficient, you got a line in, you're ready to transport. And here are her vital signs. Her heart rate's a little bit fast, her blood pressure's 98/54. Her respiratory rate's fast, but she's moving air well. She's got clear lungs, okay? Her glucose is high-ish, high, not sky high. And you say she's got an adequate airway, her gag is intact, she's got clear lungs, she's moving air well, okay? So, you're going to transport her. So the question is, there are lots of things you might do, but the question is, what's the best thing you can do to help her right now? So, what's the next best step? And these are just my questions, so we can talk about lots of opinions. But IV fluid bolus of normal saline, 500 cc's, that's an option. Supplemental oxygen by non-rebreather. Get a 12-lead ECG, start CPAP. So there are options, but I think there's one that's the best. We'll talk about that, okay? Here's the third one. You're called for a 68-year-old guy, okay? He's weak, he's just kind of confused, he's got a high blood sugar, and when you get there, he's an older man, he's awake, and he opens his eyes, he looks at you, but he's just not right. He's not really making sense. He's just kind of dreamy, really not sharing the same reality that you are. He doesn't know really where he is or any of that. And he's slow to respond, and what he says doesn't make a lot of sense. So his daughter's there, and she kind of looks in on him. She says that he's been telling her that he's been thirsty and hungry. It's been several days. He's been losing weight. Sounded confused earlier, and that's why she came over. And so he's different. He's usually not confused like this. This is a change. He's got type 2 diabetes. He doesn't really check his blood sugar much, though. He lives on his own. It doesn't look like there's trauma. His stroke scale is negative. Only his mental status is abnormal. He can stand up and walk and move. And so his glucose is, I don't know what your meters say, but something like can't determine or elevated or high, right? That's what his is. So depending on your meter, that's probably over 600 or something like that. Right? And his vitals are they're okay. Heart rate's slightly fast. Blood pressure's okay. Breathing all right. He's not febrile. So when we're done with this, we'll talk about this question, which is what's the most likely explanation for his confusion? So is it carbon monoxide toxicity, or elevated serum osmolality, or diabetic ketoacidosis, or an elevated blood CO2 level with respiratory failure? So we'll talk about all this. And some of you may know all this, some of this may be new stuff to you, but it's interesting stuff, and it's nice. You can already start thinking when you're evaluating and transporting a patient, hey, why is this patient this way? I know his sugar's high, but what's going on? Why is he confused? A lot of people have high blood sugars. So anyway, I'd kind of like to talk about some of that as we go through the basic objectives, all right? So, objective number 1 from the Dane County, I think it's Dane County, this is their deal, right? Explain the role of glucose in the cells. This stuff I'd like to kind of whip through, all right? Glucose is a sugar. It's a fuel for the brain. That's what your brain wants. Your brain can also use ketones. When it's really stressed, your brain doesn't like ketones. If any of you have done like endurance sports and you hit the wall, that's kind of because the glucose is not really so great. You're using alternate fuel and it makes you feel fuzzy and really lousy. But that's the backup. If you have an altered serum level of glucose, that can cause changes, including altered mental status. Either way, high or low. And the serum level in the glucose is regulated by hormones in your pancreas. So there's a range that's where you want to be. And insulin and glucagon act to keep it in that range. So you've always got some insulin and glucagon doing their thing to keep you in their range, okay? And I don't think we really need to go into much more detail. Here's glucose. We'll move on. There we go, that's glycolysis. Some of you maybe remember, so in your liver you've got stuff called glycogen, which is stored glucose. And if your liver, or if you need more glucose, your liver can break up the glycogen, glycolysis, and get you glucose. And that turns into pyruvate, which some of you may remember goes into the Krebs cycle. Anybody want to go through this?
There we go.
That's how you take those carbon molecules and you get energy. ATP. All right? ATP. So, feel free to talk about that later. So, what happens with glucose? This is a lining of an intestine. So, you've got glucose out here in your intestine, right? So, sodium helps to pull it in to the cell in your intestine, in the lining of the intestine. And then there's a sodium-potassium pump, and that moves it out into the tissue space, and then that goes into your bloodstream. So it's very complicated. There are all these cool pumps and blah, blah, blah. But the point is, your body takes the glucose that you ingest, pulls it into your system to fuel your brain and your other tissues. Here's a more complicated. We can just move on. But your brain, actually I'll go back. So your brain weighs about, I think it's about 2% of the mass of your body, and it uses, I think, 20% of your glucose. So your brain is the big user of glucose. Our muscles and all, but brain really is highly metabolic. Yeah?
So you get these highly endurance runners that run in, the marathon or whatever. Will it use their glycogen in the liver for that?
Yeah, they'll use some glycogen in the muscle and the liver, and they'll burn fatty acids. That's the sort of the backup.
Okay.
And they can get ketones produced out of that. So, yeah, that's hitting the wall. Is kind of when you used up your glycogen. Okay, so we'll move on from glucose. I don't think there's a lot of money other than there's a range that you're comfortable in, and if you go outside of that range, you start to get ill. To explain the role of insulin. So insulin's a hormone made in your pancreas, and it does a lot of things actually, but it primarily helps pull glucose into your cells, out of the bloodstream into the cells. Okay? So. And these are just cut and paste things from the website, so we don't have to read through it all. But hormone, it plays a number of roles. It regulates how the body uses and stores glucose and fat also. And the body's cells rely on insulin in order to take glucose from the blood for energy. So if the glucose is sitting around your blood, it doesn't do any good if it can't get pulled into the cells, okay? And insulin helps control the blood glucose levels. It signals the liver and the muscle and fat cells pull the glucose out of the blood. So insulin is also how you store that energy, right? It is involved in storing glycogen. And 5% of the mass of the liver might be glycogen. It's pretty good. The liver's a big organ, so it's quite a lot of fuel that your liver can store. Type 1 diabetes is when you stop making insulin. And usually it's younger people. They get probably some viral illness and it knocks out the beta cells in the pancreas that make insulin. All of a sudden, they've got a pancreas that doesn't make any insulin. And if you don't make insulin, you can't pull the glucose out of the blood effectively. And lots of other things too. Ketones produced, but if you get high ketones and sort of not unregulated, you can get ketoacidosis. So people with type 1 diabetes, they use insulin. They don't get managed with other drugs. They need insulin. That's what they lack and what they need. Type 2 diabetes is different, and it's much more common. It usually shows up later in life, typically linked to things like obesity, somewhat genetics, diet, all of that. But the problem is often described as insulin resistance. So it means you've been making insulin. In fact, you've been making tons of insulin because you've got more energy than you need, and your body's always making all this insulin to pull off the extra glucose. And eventually what happens is the body becomes less, the insulin becomes less effective. The other thing that happens though is that the pancreas often starts to kind of burn out, and you actually stop making insulin too. So some people can get really low, almost like type 1 diabetes, where they're hardly making any insulin, more because their pancreas burns out or the cells get sort of replaced or infiltrated with other tissues. So type 2 diabetes is a bigger spectrum in a way of people who just make excess insulin and who are resistant to those who hardly make any more insulin. And their treatment is much more complicated as far as the types of medicines. Some of them use insulin, a lot of them use oral drugs, some of them use both. So that's not much more to say about that. Hypoglycemia. So hypo means below or low, right? Glycemia that's blood, emia, and glyce is glucose. So low blood sugar, right? Hypoglycemia. So there are symptoms and signs, and it doesn't really matter, but it's maybe helpful to think about. Symptoms are things that people describe to you that they feel. Signs are objective things that you can see when you look at a patient. Okay? So rapid respiratory rate is a sign. Shortness of breath is a symptom. Okay? And this is a little nitpicky, but symptoms are generally nonspecific, and maybe it's helpful to think about them as neurogenic symptoms, which are autonomic. So that means produced by like sympathetic nerve output, like fight or flight response kind of stuff, versus neuroglycopenic. So neuroglycopenic means low sugar, glycopenic neuro. So things that are caused by the brain actually feeling the low blood sugar. So the brain directed. Okay. So the neurogenic symptoms are the common ones. Those are the things that people feel that alert them that, hey, I need to eat. I'm not feeling right. I need to do something. So they're still thinking straight. But maybe they get tremor, palpitations, they feel anxious, they get sweaty, hunger. Those are sympathetic nerve based, okay? Neuroglycopenic are more like cognitive impairment. They're starting to get fuzzy and a little goofy, right? Because their brain is unhappy now because of the low glucose. And if that gets really low, they can get very sick, seizure, coma, and stuff like that, right? So hopefully you see people before they have neuroglycopenic symptoms, but often you're there because they do have the neuroglycopenic symptoms. They're not acting right. They're not eating when they should. They're not checking their blood sugar, right? All right, so recognition of the neurogenic symptoms, hey, they can treat themselves, right? That's their warning sign. How many of you have seen people who have really low blood sugars but they don't feel it? Yeah, it's really common, right? And that's one of the problems, is that if people go low enough, frequently enough, they'll start to kind of not recognize it, right? They kind of get, it becomes like a new normal. And so you can't rely on that. You should still check your blood sugars. It's not a reliable thing. And other things can affect that. Those neurogenic symptoms, like if they've had previous low blood sugars, if they've had recent exercise or sleep, things like that can interfere with those symptoms. All right, signs. So signs of low blood sugar. I don't know, anybody have any particular thoughts? I think heart rate might be up a little, right? Just because they're kind of agitated. I think the big ones are these neuroglycopenic. If they're so sick that their brain's struggling, you're going to see it in that they're impaired, right? So hyperglycemia, they're all on the screen, but you guys could tell me these. But do you have anything to add to these? Any things that you see out in the field when people have high blood sugars? So polyuria means too much urine or lots of urine. Polydipsia, dipsia is drinking. Polyphagia, phagia is eating, right? So I don't know how often you really see this. I think it's, most of the time they don't tell you this. I think weakness, nausea, vomiting, confusion are the ones that you see more often. Or you see people who don't have any symptoms, right? You get called because somebody checked their blood sugar and it's 270 and they feel fine. And they're probably not having any symptoms because they're probably not having an emergency at that point. Yeah.
Both my niece and nephew had the opposite as far as eating. We couldn't get them to eat. They wouldn't eat because they just kept saying they were never hungry.
Yeah.
And their blood sugars
when they were high?
Well, when we first found out, their blood sugar was like up to 800.
Yeah, and maybe they were just having bad nausea or maybe abdominal pain too, depending on the cause. Yeah. So these are just general, right? They're going to vary. But that's sort of the classic, oh yeah, I've been peeing like 10 times a day and I drink 5 liters of water and I've been eating like all the time. Well, but you really don't hear that now. So signs of hyperglycemia. I think dehydration is the big one, right? A lot of people who high blood sugars, they've just been peeing out all this fluid because their blood sugar's been high and their kidneys dump out all this extra glucose, and so they urinate. So then they may have a fast heart rate, they may be breathing fast, they may get altered mental status. So sweet breath odor, this is just for people with diabetic ketoacidosis. That means they're relying on ketones and they've got this ketoacidosis. Anybody smelled that or noticed that on a patient? Yeah. It's like acetone. It's kind of that fruity smell. So medications. So from the EMS perspective, I think maybe it's worthwhile thinking, okay, how do they treat the diabetes and how is that going to maybe play into what's going on or what I think is going to happen now. So insulin, right? A lot of people take insulin. Insulin's typically, it's never oral. It's always injected in some form, usually subcutaneous. You're not going to see people on IV insulin, I don't think. Some people have a pump. Some people do it a few times a day. There's really long-acting insulin. There's really short-acting insulin. Just depends on their regimen. Metformin. Anybody heard of metformin? You guys have heard of that? So that's very commonly used for type 2 diabetes. That is probably the most common drug used for type 2 diabetes. And metformin is, we'll talk more about this, but that's almost always the first choice for people with newly diagnosed type 2 diabetes. Sulfonylureas. So that's probably worth knowing that term. It's on the objectives of the detailed list. And the reason why is because these are also common drugs, but they're really known for causing low blood sugars, for hypoglycemia. They're old drugs, they're inexpensive, and they're helpful for managing diabetes, but they can cause really low blood sugars because that's what they do, they lower your blood sugar. And then there are gazillions of other classes of drugs that, Januvia and whatever, there are all sorts of different drugs, and I think they seem to change week by week. So metformin. So metformin is great because it actually improves the action of insulin. So it helps your body pull the glucose out of the blood in a normal way, right? So if there's excess glucose, it pulls it out. It interferes with your liver making new glucose, gluconeogenesis. So that's another way that it keeps the blood sugar from staying high. But it doesn't really cause low blood sugars. It just helps keep it from going high. It doesn't directly abnormally lower your blood sugar. So it's a great drug, right? It works really well to do the right things without going too far in the opposite direction. So that's the main reason it's often the first choice of drug for people with type 2 diabetes, for people who have this insulin resistance. And this is just from an up-to-date website. We don't have to go through it, but it's also been shown to decrease food intake and body weight, which is perfect, right? Because typically those are issues for people with type 2 diabetes. So metformin, great drug. You're not going to see people with hypoglycemia from metformin. If that's all they take and they're low, I don't know, recheck your glucometer, because I don't think that's likely the cause. Maybe they actually take something else. So sulfonylureas are the opposite. They're also widely used, but they actually stimulate insulin secretion, right? So they can bottom people out. And they only work for people who actually have a pancreas that still kind of works. You have to have some, insulin production. And the ones that usually get used are the short-acting ones. And here are glipizide, glicalazide, glimepiride. I don't know the trade names. It's really not particularly important. But there are two, glyburide and chlorpropamide. And that's on the Dane County thing, chlorpropamide. They want you to know it, I guess. But glyburide is probably the one you're more likely to see. And those are longer acting, and they are particularly known for causing hypoglycemic events. So glyburide, hypoglycemia, especially in older patients, and it'll just last and last and last. So you'll see them, and you bring them to us, and they seem fine, and you know what? Half an hour later, they're low again. And then we have them eat, and they hang around a couple hours, and 3 hours later, they're low again. And so those are people that, even if they look great, they're going to probably end up staying in the hospital overnight. And sometimes they even end up on a dextrose infusion, just because that glyburide is just bottoming them out. And it can be people who've taken it for years, and for whatever reason, they just start to have trouble. Connie, you've seen that, I know, years ago. We don't see it so much anymore. I think people finally kind of have moved away from glyburide. But so if you see somebody like that case with that guy, the first case, right, 73-year-old guy, you give him some dextrose, it's all good. If she tells you he takes glyburide, well, that's great. And if you tell us that, that's great. Because you know what? I'm going to be on the phone saying, hey, this guy's going to come out of the hospital. That's just for sure. Because,
or he'll be back in 3 hours.
Yeah, or he'll be back in 3 hours. So that's a really nice piece of information, if you guys know it, to share with us. Because we're going to use that to manage to figure out our plan. Whereas if all he takes is metformin, I mean, not that guy, but let's say that guy just takes short-acting insulin. Well, then he's probably going to be fine, right? Short-acting, going to be gone. So if you guys know the medicines, or you can get that information, that's really helpful, because sometimes we can't, especially if they're like from out of town, maybe they're up at Dallas, or we can't get records or something. So that's always great information for people with hypoglycemia is how do they manage their diabetes. This is a table, just all the different drug classes, all these various inhibitors with crazy names, and we don't need to know all that, but there's a whole wealth of other drugs for type 2 diabetes that a lot of people are on. Metabolic syndrome, they wanted to touch on this. I don't think this is an EMS issue, this is like a public health issue, but maybe that's why they wanted to talk about it, just for general health. So metabolic syndrome, this used to be called, I think, Syndrome X about 15 years ago. It's basically a cluster of conditions: high blood pressure, high blood sugar, excess body fat around the waist, not so much, but centrally around the waist, abnormal cholesterol, triglyceride levels, and all of that package leads to a risk of coronary artery disease, stroke, and type 2 diabetes. That makes sense. And insulin resistance is probably sort of the key factor in that. And here are some factors that increase your risk of having metabolic syndrome. Increases with age. Certain races, Mexican Americans appear to be at the greatest risk for metabolic syndrome. Obesity, and there's a graph over there. The one on the left is an apple shape. That's the more dangerous shape, as opposed to the pear shape, which isn't dangerous. So it's the abdominal girth, not the hips. People with diabetes, that's kind of part of metabolic syndrome. And they talk about other diseases like non-alcoholic fatty liver disease, polycystic ovary syndrome. Those are kind of linked to this metabolic syndrome. So I don't think that's something that you're going to talk to your patients about directly out in the field on EMS calls, but good information. The treatment is pretty obvious. Healthy diet, weight loss, physical activity, don't smoke. Treat your high blood pressure, treat your diabetes, treat your high cholesterol, medications if you need it. If you can get away with the lifestyle modification, great. So let's go on. Insulin pumps. They wanted to touch on insulin pumps. I don't have an insulin pump. I don't know if anybody here does. I don't think we have any demos. So I just got some pictures. And you guys have seen them. Have all of you seen them in the field, pretty much? So, my quick thing, and I think you know more than I do, but if you think it's causing the patient to be low and is harmful, just disconnect it. If they're with it enough to turn it off themselves, well then they're probably not really low, right? If they're obtunded, just pull the needle out of their skin, so you know they're not getting any more, and then you can figure out the rest later. That's my advice. I don't know what you've been told, but then you know for sure they're not getting more insulin. They're pretty cool. They've gotten smaller and smaller. They've got, basically there's a catheter there's a pad, an adhesive pad. There's a little catheter that sits under the surface skin, and it just releases insulin and then it's absorbed into the system. And it's, they can program it to sort of match how they eat, so they get a bolus of insulin with meals, and then there's a basal rate in between, and then they can adjust if they need to give extra boluses to match high blood sugars, or cut the dose if they're going low. And here's just another graphic. There's a reservoir with the insulin in it, there's a battery, there's the tubing, and then all the operating buttons. And I think they can store all the info. They don't sense the glucose, they just tell you what's going in. I'm sure that's coming. I don't think that's mainstream yet.
And we've had these where we've had them fail for the overdose. That's what used to be common. Maybe they've gotten better.
Yeah, I think the more common thing is that people go high because there's a problem with the delivery, like the tubing gets kinked or it becomes dislodged or something like that. But sometimes they'll get too much, or I don't really know why. I never quite know what the problem is, but that's always the risk, right? So anyway, pumps. I think pumps are great for people for whom they work well. They're a really great way. They're not a pancreas because they're not sensing the glucose and then responding, but they're like half of the pancreas. Right? They're at least sending out the insulin. But it's no big deal if you pull out the tubing, the catheter. It's not a big deal. I mean, if they're awake and alert, let them troubleshoot it. But if they're not alert, you just take it out. This is just the objectives ask you to identify, comparing different pumps. Well, all I know is some of them have different batteries, some of them are bigger or smaller, some of them have a bigger or smaller chamber. There are all sorts of things. It's like buying a washing machine, I guess, right? So we'll go on. This is just on one of the websites, I think a Medtronic site maybe, they have a graphic for patients about how to troubleshoot if there's a problem. And basically, I think the reason I put this up here isn't to go through it all, but these patients really know about their pumps, and I think those of you who have seen them, they're usually pretty like, hey, don't mess with my pump. I need to check my pump. Rightly so, right? So if they're awake and alert, you just let them tell you about their pump, because they know a lot about it. Yeah.
Also, we've seen this. We know of at least one person that has a pump that looks fairly similar to this, but it delivers heart medication. So make sure that it is indeed an insulin pump. If you're going to disconnect it, that it isn't something that may be hooked into the atrium.
Check their medical alert bracelets.
It could be a baclofen pump.
Yeah, baclofen pump. Sometimes some of these chronic pain patients have other anesthetic drugs. Usually those are somewhere in their back sometimes for some of them. But so anyway, we'll go on. All right, so questions so far?
Insulin, is all insulin required to be refrigerated?
I think so. I don't know. You know, I've never seen insulin that isn't, but I don't really
It can go bad if it's not kept cool.
Yeah.
So if they don't keep it in a bag or something where it keeps cool, it will go bad.
Because that's one of the places I look if I find something that's down or altered. We'll go look in the refrigerator. Sometimes there's something good to eat there.
Yeah.
Sort of pie.
Walk out with a beer. So I thought if it's okay if we got a few more minutes, is that all right? Why don't we just talk about maybe just a little more advanced concepts, things that we deal with more on our end, but are helpful, I think, for you guys to think about. Some of you know this stuff, some of you it may be newer. But particularly these hyperglycemic emergencies, right? low blood sugar, hypoglycemia, it's pretty straightforward. You're going to give them oral glucagon or IV dextrose and figure out do they need attention or are they fine. And that's pretty much no matter what's going on, that's going to be the way you deal with it. But hyperglycemia is different. There are lots of potential causes, and some people are not the least bit sick. They just run high. You all can think of several people in the community who always run really high, and they don't need you to come out to their house every night, right? It's just the way they are. Not that it's good, but there's the high blood sugar, no symptoms or no issue acutely. And then there's the high, really, really sick. There's the really high, maybe not so sick. Really high, really sick. It just, you can't use the glucose alone to determine if they're sick or how sick. Okay? It's just one piece of information. Whereas with hypoglycemia, they're low, right? If their glucose is 30, you know what you're doing, right? So hyperglycemia is more interesting, I think. So there are two basic hyperglycemic emergencies, and one is diabetic ketoacidosis. From now on, we'll just call it DKA, right? And then there's something called hyperosmolar hyperglycemic syndrome, or HHS. Who here has heard of HHS? Yeah. Okay, so this is a pretty new concept. So we'll talk a little bit about it, and the goal isn't for you to be experts in HHS, but what I'd like to do at the end of this is for you to maybe think, hey, is this maybe DKA or is this maybe HHS? So there's some clues, and sometimes it's not clear. So DKA and hyperosmolar hypoglycemic state are two of the real serious acute complications of diabetes, hyperglycemia, okay? So DKA, in its name, it's characterized by ketoacidosis and hyperglycemia. So ketoacidosis means that your body is not, you don't have any insulin around, and you're kind of starving in a way because your tissues aren't getting the glucose. Right? You get tons of glucose in the bloodstream, but your tissues can't get it because there's not insulin there to pull it in. So that's why people with undiagnosed type 1 diabetes, they're often thin, they've been losing weight, they've been drinking and peeing, and they've been hungry, and they're not sedentary, overweight 60-year-olds, right? They're usually like 12-year-olds who look fine, except now they look really kind of thin and wasting away. And that's the reason why. They're just breaking down all their tissues to try to get some fuel, because they can't use their glucose. So they're burning up all their fat. And as a result, they're doing this ketosis. They're relying on ketones. And one of the effects of that is that type of metabolism causes acidosis. So their pH starts to go down. They become acidotic. Excuse me. And that's really the issue. It's not the blood sugar. It's the acidosis. That's what the illness is. And because they can have high blood sugars for weeks, but it's only when they become really acidotic that they get sick. And that's often how young people with diabetes, type 1 diabetes, present. The first time they come to medical attention, they're in DKA, okay? So usually it's going to be your younger patient who looks sicker. Their blood sugar will be high, but it won't necessarily be sky high, like 700 or 800. It will often be like 300, 400, something like that. And the problem isn't the blood sugar, the problem is the acidosis. So when you bring them to us, we work on the acidosis first. That's the key, and all of the effects of that, okay? HHS is the opposite. Oh, thanks. Yeah, I'm sorry, I got a cold, but I don't think I'm infectious anymore. HHS is different. It is all about the blood glucose and its effect in the serum. So HHS is usually your older people with type 2 diabetes, often untreated, or maybe they have a hard time kind of eating and drinking or taking care of themselves, and their blood sugar starts to go up and up and up and up, and it often occurs over days. And what happens, the illness of HHS is it's not the blood sugar directly, it's the fact that they have so much sugar in their serum that their serum is so concentrated, or it's got so many particles in it, that it makes the brain unhappy. So it's like a supersaturated solution, right? It's got all these solutes in it. So we'll talk more about that. But that's the effect on the brain that's causing trouble. It's not just that the glucose is high, it's that the plasma is so saturated with particles that it affects the brain function. So DKA usually evolves pretty rapidly, 24 hours. And HHS is usually slower with more of the classic polyuria, polydipsia weight loss, several days. Neurologic symptoms are the most common in HHS, and that's because they often will get these very, very high blood sugars, and it's been going on for days, and they will get confused, obtunded, even comatose. DKA, usually they'll have hyperventilation and abdominal pain. If they start to get obtunded, it's because they're so acidotic that they're sick. It's not really the glucose, it's the acidosis and their abnormal metabolism. So they can both get really sick neurologically, but in general, HHS is going to be more of the neurologic trouble from the high blood sugar. And it's more dangerous as far as mortality, actually. And so the treatments are a little different depending on which one you're dealing with. So plasma osmolality is the term we use, and it's the concentration of a solution as expressed by the number of solute particles per kilogram. So if your blood sugar gets high enough, it's a problem just because of all those particles in the solution, okay? And what happens is if that's what your plasma is like around your brain, well then the water that's in your brain cells is going to shift out of the brain cells, right? Because it's got this really, really concentrated solution, so the water will flow to kind of match that. So the brain cells start to shrink down, they literally get dehydrated, and you get these neurologic problems. And it's sort of, you hit a threshold where you then really start to get into trouble. So you can have all sorts of weird neurologic features from that. Hemiparesis, seizures, visual disturbances. And again, the mental obtundation may occur in DKA, but it's not because of the hyperosmolality, it's the acidosis that causes it. And so when we treat these people, we got to treat the actual issue, not just their blood sugar, but why are they having trouble. One of the clues is abdominal pain. A lot of people with DKA will complain of abdominal pain, just because that ketosis seems to produce abdominal pain and nausea. So that's one clue. Usually you don't see that in HHS. And the abdominal pain, sort of the worse the acidosis, the more they might feel abdominal pain. It's not the blood sugar, it's the acidosis that does it. So, here's just a little chart. We don't have to really go through this. Well, I guess we can spend a minute. But so, DKA, ketoacidosis is the problem. HHS, it's not an acid problem. They both, this is extracellular fluid volume. They're both usually kind of dehydrated. The osmolarity isn't the issue in DKA. It's definitely the issue in HHS. DKA, they'll have a pretty, their glucose will be up, but it's not going to be through the roof, at least not compared to HHS. HHS, 900, 1,000 even. You don't really see that in DKA, at least not usually. We'll talk more about this, but potassium's a big issue with DKA because of just with the acidosis. They have to have insulin. HHS, I don't know, but insulin's not their problem, right? Their problem is just the hyperosmolality. This DKA usually comes out rapidly. HHS is slowly. Again, maybe older person who lives alone, they have a hard time getting fluid. They get a little dehydrated. Their blood sugar goes up. They don't take their meds. They feel worse. They drink less. We'll just skip this. This is not worth it. So here's a particular feature of DKA that you may see. I don't know how many of you have seen this. Kussmaul respirations. I don't know who Kussmaul was. It's basically respirations from severe acidosis. So it's this very deep, rapid breathing. And the reason people do that is their brains are telling their lungs to do that because they're so acidotic, their blood pH is so low, that to compensate for that, the patients will blow off all of the excess carbon dioxide they can, because carbon dioxide is kind of like an acid in your bloodstream, right? And so they'll produce this tremendous ventilation. And that's really the only thing keeping them from really tanking, is the fact that they're able to blow off this carbon dioxide, okay? And so we talk about tidal volume, that's the amount you take in per breath. And the minute ventilation is how fast you're breathing multiplied by your tidal volume. That's how much you ventilate in a minute. So these people have huge minute ventilations. And you'll see that, maybe next you look for it when you have a DKA patient. But it's really important because if they don't do that, their pH is going to just plummet rapidly if they can't continue to breathe like that. So, you guys don't do RSI, at least most of you don't. Bob, you've involved in this maybe. And in our end, in the emergency department, if we see someone with DKA, maybe they're going to get intubated at some point. Just like if we're going to transfer them or something, we may want to protect their airway at some point. But boy, you got to really be careful, because if you paralyze them with drugs and sedate them, and you put them on normal settings, right, for a normal 70-kilogram person who would normally breathe, in a few minutes they're going to die.
Yeah.
Seriously, this is like a clean kill. It's you can't do that. You have to observe what their minute ventilation is. You got to match that, which is awkward for a respiratory therapist with a ventilator. That's not, But you really have to think, because it's all acid base, right? And your breathing is a direct effect on your acid base balance. So you guys don't have to worry about that in general, but if you do have to assist ventilations with someone in DKA for some other reason, or maybe they vomited and they've aspirated, you just try to think about, hey, how fast were they breathing? How much air were they moving? Let's try to do that, because that's really important. Okay. So before we would intubate them, we would check their pH. We might give them sodium bicarbonate, which is like a base to neutralize acid. We would do things to try to stabilize so that we've got a little room to work with. Okay. Yep.
In a case like that, is there anything you can target capnography to try and
it's
see?
going to be very, very low,
Yeah.
because they're going to be blowing off so much
Right.
CO2.
Right.
Yeah. So I don't know what to tell you, except you would expect it to be low because they're hyperventilating.
Yeah.
Yeah. If it's not low, it's kind of like people with asthma, right? If they're really working hard, they better have a low CO2.
Yeah.
Because if they don't, and they're working that hard, that's a warning sign, right? Like, they should be blowing off excess CO2. If they're not, it means that they're not keeping up.
And if they're in ketoacidosis, you really don't want to try to encourage them to slow their breathing down. They need to
No, they're going to breathe like that. They don't know. That's not their
That's- they have no
voluntary breathing.
control.
That's their that's their very brainstem breathing going on. So here's a video. Let's see if this works. Kevin, you might have to click on the image to make it go.
Basically, when he went to bed last night, his sugar was what? 99. Yeah, and then when he woke up this morning, he had a little trouble waking him up, and he was breathing like this, right? When was he diagnosed with diabetes?
2 years ago, I'm sorry. At 3 years old.
Okay, 3 years old. Okay, so he's 5 now. Okay, and is this the second time he presented with breathing like this, or has he ever?
I've never seen this before.
You've never seen this before. Okay, so this is the first.
So he looks like he just played a soccer match or something, right? He's just huffing and puffing. His lungs are fine, his airway's fine. It's just that it's his metabolism that's causing that. Okay, so he doesn't. The treatment isn't oxygen or any of that. It's fixing the metabolism. So we got to go back to the.
PowerPoint.
I tell you, these AV guys. Can you?
Let's see.
Are we okay time-wise?
We're fine.
You tell me otherwise.
Yeah, we are.
We're almost
great.
done. We're just going to go through our quiz questions in a second. So Derek's question was about DKA. So I think the clue is they look sick. That's
Yeah.
really it, right? Because like I said, people with a blood sugar of 320 and they're fine, they're fine. They're not in DKA probably. I mean, we might do the tests and look for it. And the other thing is they will often tell you if they've had it before. They know, and they know to look for it. That's part of their own management, is to monitor for DKA. A lot of times, almost always though, DKA will be triggered by something, usually some other illness, or they didn't take their insulin, right? So sometimes like teenagers who want to lose weight might not take their insulin or something. It's something to DKA. Or maybe people get sick with nausea, vomiting, and they decide, well, I can't eat, so I better not take my insulin. DKA. But maybe it's somebody who's had diabetes for 20 years and now they're having a heart attack, or a stroke, or sepsis because they got pneumonia or urinary infection, like systemic urinary infection. Those are all triggers for DKA. or hypoglycemia in general, hyperglycemia in general. Can we get back to the?
Yeah, go ahead.
Well, that's it, okay. So, management. So, it kind of doesn't matter if it's DKA or HHS as far as what you're going to do, but it's helpful to think. So DKA, from the EMT standpoint, you're going to identify the hyperglycemia, you're going to say, hey, this person's sick. And really, your best treatment is going to be volume, right? Because they're going to be dry, and they don't need insulin right away. They need some volume. That'll help them. And your protocol has right in there, like go to the non-trauma shock protocol, and you can give a 500 cc bolus and reevaluate. So I think that's the treatment. That's what's going to help them before they get to where you're going. The other thing you could think about is there a trigger that we might identify? So if they're complaining of chest pain and they're maybe 43 and they smoke and they've got diabetes since they were a kid, you know, that's good information. Maybe you get an EKG. You know, I wouldn't do the EKG if it's going to slow them down and they're sick and they got DKA. But that might be something that's a trigger, right? Same thing with pneumonia, right? If they're febrile, they've got productive cough, all that. Because when they get to us, they may not be able to tell us much, and maybe there's no family there. So if you guys can get any of that information, very helpful. Think about what's the trigger for them having DKA now. Or maybe it's, you know, there's also self-harm, or there's, you know, there are other reasons people do things. So any history that you guys can provide related to those triggers is great. From our standpoint, we're going to kind of do the same thing. We're going to give them saline and usually tank them up a bit. We're not going to do a ton, but we're going to do some initially. The biggest thing in the short term in the ER for these folks is their potassium. And they can have a very, very high potassium, a normal potassium, or a very low potassium in their serum when we measure it. They almost all will have a very low body-wide potassium because they've been urinating a ton, right? They've been peeing out because of this high sugar. But in the short term, if they're really dry and their kidneys aren't working, their potassium may be way up. Or maybe it's really low. So we really need to know their potassium. We don't start the insulin right away because for people with a really low potassium, insulin is actually a treatment for people with really high potassium. If we need to get it down quickly, we give them a bolus of insulin plus a bunch of dextrose because it shifts potassium out of the serum into the cells. So if they come in and they've got a low potassium and we're like, oh, we got to get the insulin, let's go, we can really tank their potassium and they can have things like VFib arrest. So the insulin's really not the priority. So like if you're on a call and some family member says, hey, I've got their insulin that they didn't take this morning, should I give it to them? Don't give it to them. The insulin, there's time to figure that out. Okay? Volume, give them volume, great. That's going to help. And then identifying the precipitating cause. And there's lots of other stuff that goes on. I'll just show you a couple of quick EKGs just for fun. So I know you guys see EKGs and you look at them. These are some that reflect severe hyperkalemia, high potassium. So this one, your monitor might read ST elevation MI because these big. But look at see these T waves? They're huge. They're way big, tall, narrow T waves. That's one of the clues of really high potassium. So high potassium can just be bizarre. You can see all sorts of weird EKGs. So that's what this is. And if someone has evidence on an EKG of high potassium, we're going to treat them with stuff even without knowing the number because we know, boy, it's so bad, your heart's really, really close to having trouble.
Would you see those T waves on a 4-lead strip as well?
I don't know. I don't know. I think you're just, and you don't always see them. I mean, it's just a clue. So I don't think it's.
T waves, I think.
I think that's one of the most common and relatively early signs is really tall peak T waves.
So normally we might do just a 4-lead begin with and
Yeah. Yeah.
follow up with a 12.
Yeah. Well, I mean, you could do. Again, I think it depends on your setting and what you're doing. I wouldn't delay, in general, monkeying around with EKGs if someone's sick. But we're going to get it right away because we're going to want to know their potassium because it takes a while for us to get a lab result back, right? So we might get a clue as they arrive to what's going on. And also then STEMI, right? You got to be careful what they call us. You know, you just got to think. Is my point. Here's another one. That's bizarre looking, right? What's that? It's like it's hardly an EKG. Is that like some huge bundle branch block, or what's this really wide QRS complex? I don't know. If it looks bizarre, it's probably hyperkalemia. Here's another one. What's that? Right? It's the heart
like
is so
pictures.
messed up electrically that this is what you're seeing because the potassium is so
But you're
high.
still in the sinus.
So that's a very dangerous thing. They need treatment rapidly to lower their potassium. So if you give them some volume, what's going to happen? Potassium's probably going to eke down. That's not going to hurt them. Here's an example of severe hypokalemia, and this is less impressive visually, but I'll show you just for interest. So like here, lead 3 we can look. So here's the QRS complex, right, the narrow spike. And then normally there's a T wave, which is just a discrete little wave, and then it's flat until you get the next QRS. But here we've got like the T wave starting, but then there's this really long, wide, so that's actually a U wave next to a T wave. So if you were to calculate what's called the QT interval, the distance from the Q to the end of the T wave, it's like almost the whole thing is the QT interval. Normally it's less than half of that space. So people like this, with really, really low potassiums, I mean, it's not obvious, this is pretty subtle to pick that up, but if you saw that, you thought, boy, I bet their potassium's really low. It is. This is a case I just got off of a website, a QG website. This particular patient had a potassium of 1.9, very long QT interval, actually went into a VFib arrest. So that's the kind of person, hey, if you just go giving them insulin, don't do that. You gotta know their potassium. So that's for us on our end what we're worried about. We're not worried about giving them insulin.
And that's a very common thing when you get to the scenes where the family will say, well, should we give them their insulin?
Yeah.
That's very common.
Right. I'm talking about like severe hyperglycemic emergencies. If they're there and you're not sure if they need transport or whatever, I mean, I don't know what to say. But the patients can, if they're alert and they want to do something, they can do something, right? Usually these people are very, very sick. So.
There's no such thing as a potassimeter, is there?
Well, kind of. We've
Well,
got
it's
this
coming.
ISTAT
Yeah.
thing, but not for. I'm sure there are paramedics that have these.
We used to have them, they never worked.
Yeah.
Oh, it didn't work?
They didn't work comparably.
So anyway, potassium's a big deal on our end. HHS, the treatment, it's really more on the osmolality. It's really not so much about the metabolism. It's things like their sodium and their potassium and all this other stuff. And those folks, you actually kind of want to bring them down gently. The brain doesn't like big, huge shifts, so you kind of slowly bring them down. Anyway, that's kind of the spiel. These are the objectives again, running through them. We kind of went through the basic stuff. We talked about the medications. So metformin, commonly used, doesn't lower your blood sugar, just kind of tries to keep it normal. And glyceride's a long-acting one that tends to bottom it out and keep it low. We talked about hyperglycemia and DKA and HHS, the two different presentations. And so back to our questions, okay? So here's our case one, 73-year-old guy, blood sugar's low, 33, you give him some glucagon, then he gets a little dextrose. So which hypoglycemic patients are least likely to respond to glucagon? We didn't talk about this. Sorry.
B.
But you guys know all this because it's right in your protocol. Yeah. Chronic liver disease, and why is that?
Glycogen.
What's that?
The glycogen issues.
Yeah,
There's no glycogen.
they're not as
No
likely to be
storage.
able to store glycogen, so you don't have a well there to take from. Chronic alcoholics would be another one. I mean, you may not know if they have liver disease, but that's another one. Back to the liver and DKA. People with DKA have to be, or with type 1 diabetes, they have to be really careful about alcohol. Because if they drink, they go out and they drink excess alcohol at night, and then they don't eat, that's a problem because their liver has a hard time bailing them out. So they really have to be thoughtful about that. It's not like a moral thing to drink. It's because the liver can't bail them out as quickly. So yeah, patients with chronic liver disease. Question 2, we gave our glucagon, we got a better mental status. She tells you about the meds that he takes. So which medication is likely to cause prolonged or recurrent hypoglycemia?
D.
D, glyceride, absolutely. So Lispro, this one.
Yeah.
So Lispro is a short-acting. I don't know how you remember that, but Humalog or Lispro, it's just a short-acting. It's what people usually take with meals for the rapid action, as opposed to Lantus, which is the one they take at night to last all night.
Lantus is long.
Metformin, the opposite, usually doesn't cause atorvastatin is for cholesterol. Okay, glyburide. Question 3 we'll get to. So here's a 19-year-old, diabetes, vomiting, lethargic, she's ill, she's unresponsive, she's had diabetes since she was 17, right? Been vomiting all night, dehydrated, probably the cause of her DKA, right? So why is she breathing like that? Why is she doing that? What's the answer?
D.
D, yeah. Increased tidal volume, rapid respiratory rate, huge minute ventilation, blowing off all that acid she can, okay? Now, some people might have rapid shallow breathing if they're, and maybe that starts out kind of rapid and shallow, but what we saw with that little boy was D, right? And that's Kussmaul breathing. Not many things that do that. It's going to be severe acidosis, DKA, maybe like a tricyclic overdose, something bad where they're really acidotic. Back to this periodic breathing. Anybody know what this is? I haven't seen this in a long, long time. Usually has somebody with like really bad chronic congestive heart failure. They've got really lousy circulation. And their circulation and their regulation is so abnormal. So normally the brainstem is sensing the oxygen and the carbon dioxide in the blood. Well, it's such a slow feedback loop that they'll breathe a whole bunch, and then they won't breathe for a while. And then they'll breathe a whole bunch, and then they won't breathe for a while. Instead of, studying. Yeah, so anyway, that's what periodic breathing is.
Everything's slow.
Okay, go on. You do your survey, clear lungs, moving air, oxygen level is fine, respiratory rates increase. So what's the next best step in management?
A.
Right? That's going to be helpful, worth doing. The other stuff isn't wrong necessarily, but that's not really where the money is, right? I think if you had an airway issue or a problem with moving air, sure, but usually they're not having any trouble moving air. They're just moving a lot of it. And then on to our last one. Sorry, the print's so small. This is a guy with HHS, right? Older guy, very high blood sugar. It's been a few days coming on. He's not like the DKA patient, obviously sick, breathing fast. He's just confused and not right, and losing weight, and doesn't check his blood sugars. So, why is he confused? What's the cause?
Elevated serum osmolality.
Serum osmolality, yeah. He's got too many particles in his serum. That's the answer. All right, that's it for me. I'm happy to take questions. That's the only picture I could find of you guys. You need to update your website. That's a pretty old picture in the back there. Your website is pretty old. Anyway. I know it's already getting late. I'm sorry that took a while.
So your second case resembled the patient that Dean and Dan and I were on, and she was actually
That young lady, I think I was there
that morning. Do you know her outcome? Or?
Yeah, I do know her outcome. So these guys brought a patient in, kind of like the 19-year-old. I forget how old she was.
She's 22.
And she was sick as a dog. She had a pH, I think it was 6.89.
Yeah. And Jenna was 7.
Yeah, but her actual pH was 6.89. So yeah, her PCO2 is 7, or the end-tidal CO2. So she was breathing so much that normal is about 40, right? She was all the way at 7. So that's how much, and if we had paralyzed her and just didn't, she would have died quickly, for sure. Her pH would have dropped more, incompatible with life, cardiac arrest. And so she was okay as far as we gave her fluid, we checked her potassium. I think her potassium is actually in the normal range. We gave her volume, we started some insulin, we started giving her supplemental potassium because it's going to go down. And we sent her down to UW. We sent her by med flight because she was so sick, and not so much for the helicopter, but she needed continuous good critical care. And we did intubate her before she left, which I think is a good thing to do before we put her. But I sat there with that respiratory therapist and we talked about it. I'm like, look, watch. I want you to tell me what her minute ventilation is, and I want you to match that. But we also gave her sodium bicarb, so we had a little wiggle room by the time we did that. So she got very agitated after she was intubated. She had large doses of propofol and other sedatives. She stayed very agitated for 3 days. As soon as they pulled the tube, she wasn't agitated anymore. This is like her 5th time. It's been the same every time. She's terribly agitated. They can never get it controlled with drugs until they pull the tube. And she walked out of the hospital fine. You're gonna transport her again.
She's very light.
Yes,
Well, that's a
very
good
likely.
thing.
But I mean, this, I don't know, I think she probably just had like acute vomiting illness. That was her trigger thing. She seemed fine otherwise, so, yeah.
So I didn't hear this come up in it, but with my niece who has been diabetic since she's 3,
Yeah.
she had the pump for about 10 years, developed epigastrus. Is that?
I don't
It's
know.
where they start vomiting, they just vomit, and they think it's a cause of the pump.
Oh, yeah, I don't know.
And
about
so
that.
now she has cases of vomiting, and she goes into DKA and has to be
Yeah.
hospitalized.
Yeah.
So-
Does she still have a pump or no?
No, they took that away,
Yeah,
they said
I
don't use it
I don't
again.
know about that.
But I was gonna say, if this gal sounds exactly like what my niece does,
Yeah.
she starts vomiting, and she can't, her blood sugars go high, and she goes into DKA,
Yeah.
and she's in the hospital for a few days.
It's really hard, but in theory, I think what people with diabetes, type 1 diabetes, get counseled that even if you're vomiting, you have to take some insulin. You gotta take in some sugar and some insulin. Because the insulin is not just for your sugar, it's also to prevent you from going into that other metabolism, right? So, and like some people with DKA, they're in the hospital, their blood sugar is fine. We're actually giving them dextrose because we need to keep giving them insulin
Yeah.
until their metabolism reverses. So it's a metabolic issue, not so much a glucose issue. It's a more general metabolic issue.
Yeah, she gets both.
Anything else?
Our operational plan, I think we still carry, how often are you guys giving D50 in the ER? D10 seems to be doing.
Yeah, we try not to give D50 just because you can, screw up somebody's veins. We'll do it in a real emergency, like they're really,
Okay.
or seizing or something, but I think we almost always do something else. I don't know, Lisa, you got any thoughts about that?
We've been using.
See, that's my practice, I don't know what others.
Sure you do.
We've been using the D10 and the.
Yeah. Yeah, I think that's, I mean, if they're truly comatose and you get a sugar of 8 or something, yeah, I would give them some D50, but, Dean mentioned somebody had a question about hypothermia and VFib and shocking.
Yeah. Somebody forwarded email on, we've had a couple of patients over the years where we've had the severe hypothermia where you've had the frozen limbs, where, now that the Packers are out of the playoffs, people are gonna drink more. And they tend to fall down on a 15-degree below 0 night and end up with frozen limbs.
Yeah.
So these patients, what's the whole thinking on the rewarming process for us and for?
So I don't think I will tell you anything that you don't know, but it's basically, as far as rewarming, don't rewarm them unless you can keep them warm, right?
Right.
So if you're in some wilderness situation, don't warm them up until you're sure they can stay warm, right? Because you don't want to refreeze, that's the worst. As far as like things like frostbite or extremity, injury. I think the big thing is that probably you guys learn, and I don't do this, right? I don't do what you do, but I think you have to handle them very gently if they're hypothermic because their heart is very irritable, so it's very easy with really profound hypothermia to go into ventricular fibrillation. And so you don't want to jostle the patient. If you need to do an airway, you should have your best person do it quickly and with minimal trouble, because any stimulus might put them into VFib. That said, if they're in VFib, you should shock them, because being profoundly hypothermic with a normal heartbeat is a lot better than being profoundly hypothermic with a VFib. So, but that may not work. But you shouldn't. I don't think you should not shock them for fear of because they're hypothermic. You're not supposed to shock people when they're all wet, right? But
Right.
if it's, I don't mean dry them off and shock them. I think there's, and I'd be curious, I think you guys probably learned this, but people may have an actual perfusing rhythm but you may not be able to tell because their pulse is so slow and their perfusion is so low. But you don't want to take that and monkey around and then they go into VFib. You want them having that pump that's actually pumping. So I think before you go jump into doing chest compressions, which will turn them into VFib, you should really take a minute and really check for pulses. You should really, because maybe they do have a faint pulse, right? So make an extra effort to identify before you go jump on their chest. That's like if you had ultrasound, you might look, right, to see if they have actual moving heart.
Yeah, if they're cold like that, I mean, the pads will probably still pick up something, won't they? I mean, this thing, we're always
Yeah, although I think the question is whether they're actually having an effective
get it
squeeze.
perfusing, right? Yeah,
Yeah. But yeah, if you see VFib, you should check.
right.
That was the only one that was forward.
So the rewarming, should you use the warm fluids or just?
Oh, yeah, I think warm
cold,
fluids,
or
whatever you can do to warm them, yeah. Yeah.
some Supernatural?
Oh, no, you should warm them up, yeah, warm them up, so whatever
Just
you
don't
have.
rub them for warm.
Yeah, don't rub your skin, but yeah, if you, warm blankets, warm fluid, hot packs, whatever you have.
Snug degrees in the back of the ambulance.
Snuggle up, skin to skin.
All right. Thanks for listening.
Good one.